Okay, so onward we go in terms of planning. Um, there's a lot of practical things you need to consider. So up next we have Don Pendley, who is the Director of Hospice and Palliative Care of the Home Care and Hospice Association of New Jersey. Again, Don's been a great supporter of MSA New Jersey, always coming out, providing information, giving us resources to the New York counterparts and whatnot. So we're very happy to have him here to give you some practical suggestions. And again, like before, when the presentation's done, there will be time for Q&A.
Good afternoon. Pleasure to be here with you again. If those of you who were with us in January up in Summit, I guess, probably got some of this. So if there's some repetition, I apologize for that. But I'm here to talk to you about hospice and palliative care. People seem to think that you choose one or the other, and I'd like to clarify that for everybody. They both have their time. Hospice and palliative care are very similar in a lot of ways and different in some ways. We're going to spend the next few minutes talking about what makes them similar and what makes them different. They are both in the general field of palliative care. Palliative care is the larger entity in terms of study. All types of palliative care seek to provide comfort to a patient. That's the goal, not necessarily cure. Palliative care can work in consort with cure. Hospice works to provide comfort when cure is no longer possible. Hospice is a type of palliative care focused on the dying person. Our techniques are similar, but the differences are in who gets served, how services are organized, and how care is paid for. This is how we define comfort, not just physical, not just pain, and not just the burden of symptoms, but emotional comfort, psychological comfort, spiritual comfort, and family distress. Both hospice and palliative care cover all of those needs within their plan of care. Both hospice and palliative care provide interdisciplinary care, the supervision of a physician, the active involvement of a nurse, counseling from social workers, and happy Social Worker Month, by the way. Thank you. We love our social workers. I've got a gang of them coming in on Tuesday, and I'm looking forward to it. Both hospice and palliative care are applicable to any disease type. Hospice started in cancer, but now in New Jersey and nationally, only 29% of our patients are cancer. The vast majority of them are some other type of terminal disease. So things change. Hospice and palliative care can both be applied wherever the patient lives. People seem to think that hospice is a house that you go to when things are not looking good anymore. Not true. Yes, there are in New Jersey 5 what we call hospice houses, which are residential style settings where people live until they're ready to pass. But the vast majority of hospice care and palliative care is provided wherever the patient already lives, in their own home, in the home of a family member, in an assisted living facility, in nursing homes, wherever the patient lives. We have hospices in New Jersey that have cared for homeless people who are dying on the street. We get them into a facility at some point, but we reach even them. And the purpose of both types of care is to support the family, not to replace it. Nobody comes in and spends a shift or a day, except in some rare cases, with the patient. We're there to make visits of an hour or so to provide support. And you'll see from the list that we're going to talk about later, sometimes it gets busy. I remember when my own wife was on hospice care almost 9 years ago. The house had never been as busy as when we had that hospice team coming in, making their visits. And of course, the friends and relatives who also want to be available to say goodbyes. So it's a busy time, but we do support the families. Now on to the differences. The big difference is that palliative care is what we call a consultative service. A palliative care team, usually at a hospital, sometimes in the home care division of the hospital. That team will work with the patient's physician and make recommendations about services and programs that the patient needs, and the doctor can prescribe it and authorize it. Hospice, on the other hand, the team comes right into the home and provides direct service to the patient and family, because the unit of care in hospice is the patient and family. Our plan of care includes the family's issues as well. So we provide direct service to the patient and family in the home in hospice. You'll receive a visit from a nurse, usually an hour a week at the very start, and then increasing as the patient declines. You'll probably be assigned the support of a home health aide to do patient-related housekeeping, typically 2 hours a day, 5 days a week of that kind of housekeeping support. Social workers may visit to put you in touch with services in the community, as well as counseling if your family needs that. A chaplain can be made available, not so much for religious purposes, but if the patient is a believer in a particular religion, we'll work with their clergy person to be sure that those needs are met. But the spiritual nature of what we do is more helping the patient, the person, get in touch with what has meaning in their life. And that varies for everybody. So it's not necessarily religious in nature, but being sure that you're focusing at the very end about the things that made your life important and continue to matter to you. Palliative care can be applied to both curative treatment, patients still looking for a cure, as well as patients in rehab. Hospice, on the other hand, is only for patients who are beyond cure or no longer seek cure. They're tired of the chemo and the radiation and the rest of it, and they just want to say, make me comfortable, and I'll take whatever comes down the road. Palliative care is very much a medical model. The doc plays the largest role in palliative care. In hospice, it's very much a nurse-driven model. The nurse serves as case manager and really supervises the care that the doctor prescribes. Palliative care can start anytime. Hospice is limited to the terminal phase, that a patient is terminally ill with a life expectancy of 6 months or less. Notice expectancy. Nobody kicks you out after 6 months. This is the doctor's best guess that, yes, you're likely to pass on within 6 months, and if you don't, the doctor can authorize another 6 months, and that can continue. There will come a point at which, we realize, okay, maybe it's not going to happen, and you may get discharged. You can also leave hospice voluntarily. You can revoke and say, I'm tired of all these people coming in and out of my house. I want to take a break, and then return to hospice when you feel that things are going south on you. So hospice does not include curative treatment. But it is, hospice, by the way, something that you must choose. You cannot be assigned to hospice by your physician. You have to decide, I want to go the route of comfort rather than cure because I know the cure isn't going to happen anymore. So it's your choice. Palliative care, loosely defined, there's no reimbursement stream for hospice in federal or state, for palliative care in federal or state law, so that has remained somewhat undefined. Hospice, on the other hand, is very well defined. Terminal care, 6 months or less to live. We've covered some of those points. As I said, you can leave hospice or revoke anytime you choose. You can be discharged and return. About 11% of hospice patients actually leave the program before death at some point. They'll either revoke or be discharged. So you can graduate from hospice. There are several levels of services that we can provide if the occasional visits aren't enough, that hospice usually does. If the symptoms are very severe, severe pain issues, for example, we can provide some continuous care for up to 8 hours a day, bring you back to the hospital for inpatient care if it's very intense and can't be treated in any other setting. We can also provide respite care. If a patient's been on hospice for a couple of months in a family's home and the family just needs a break, we can bring the patient into a nursing home for 5 days and let the family just have a little vacation right there at home, and let the nursing home take care of the patient for that time. And we're available on call 24/7. Palliative care is not yet reimbursable under Medicare. Usually, palliative services are paid under a home health benefit in Medicare or Medicaid or private insurance. They're billed under the physician's or nurse's own license. And usually the hospital, as I said before, is the nexus of palliative care. That's where the whole thing gets organized. Hospice care, on the other hand, there is an excellent hospice benefit under Medicare Part A, which has been around since the mid-'80s. The hospice agency bills Medicare. The family usually doesn't see a bill at all. Medicaid and private insurers also cover hospice, and as I said, it's provided through visits by the interdisciplinary team to the patient's own home. And when you get to that point, where do you start looking? The answer is always the doctor. He's the one who will either prescribe palliative care or help the patient identify a hospice if they've decided that now's the time to think about hospice for that patient. Our association's website, homecarenj.org, lists licensed hospices and home care agencies in every county of the state. There are plenty of them to choose from. Bergen County and Middlesex County, for example, each have about 19 hospices serving patients in that area. And if you're curious about which to choose, the starting point, again, is your doctor. He will probably have worked with the hospice in the past and can make a referral. If not, there is a website called hospicecompare.gov, I think, but it may be .com. Anyway, Hospice Compare. The federal government has set up a program for each of the types of healthcare providers, hospitals, nursing homes, home health agencies, hospices, that allow you to compare how the public rates them in your area. So you can put in your zip code, mine's 07076, and a list of hospices serving my zip code will come up. I can pick 3, and I can check out how families rate the 3 of them in terms of their services. So that's a really nice place to go. That's very new. It's only been up about a year and a half. If you're looking for palliative care, again, your doctor's a good starting point, but there's also a website called getpalliativecare.org that will help you identify a palliative care program serving your community. Usually, as I said, they are hospital-based, so don't be surprised by that. The other thing I would strongly encourage you to do at any age, any time, any place, do your advance directive. This is some people call it a living will. There are instruction directives where how you want to be treated under each of these circumstances is defined. My suggestion to you would be to instead complete a healthcare proxy that would identify a person who can make decisions for you if for some reason you become physically unable to express your own wishes. This is just the smartest thing possible. When my wife developed her glioblastoma, her brain cancer, I was surprised to find out that she had taken my advice and didn't name her spouse as her healthcare proxy. We had a close friend who was a nurse, and we all made our decisions together. So think wisely about who would really reflect your desires if you're no longer able to speak for yourself, and make them your healthcare proxy. I think that finishes up my slides. The 2 other things I'd like to mention, since I'm here, our association works with home care and hospice agencies. It may be that you're looking for either home health services or personal care services. Those are 2 other areas that might be appropriate for you. There's a difference, and it's on my handout, which is over on the table if you want to pick one up before you go. Home health is medically required services. Victoria mentioned a bunch of them in her presentation. Physical therapy, occupational therapy, speech therapy, and a bunch of others. You might also want or be in need of personal care, which is provided not by nurses, but by home health aides. They give you assistance with activities of daily living, ADLs as we call them, bathing, dressing, cooking, things that maybe you're no longer able to do by yourselves readily. That is not funded by Medicare yet, although we're getting very close because some of the managed care companies in Medicare are now providing those services, and that's only been true since January. But they are available through Medicaid. You may also want to talk to your county office on aging to see what's available at the county level, because they do vary from county to county. That's an awful lot in a very short time. And I appreciate your attention, and I'll be ready for questions later on. Thank you.
And again, do make use of these resources while you're here today. They're very willing to talk with you, interact with you, as you've seen so far. Don's got a table over there, and we've got the Monmouth County Division of Aging and of Veterans and Office of Veterans and Disability Services. So make a point of visiting. Even if you're not from Monmouth County, I'm sure they can help you a little bit with the kinds of services and how to find your contact in your office.